Hello, my name is Colleen and I will be taking you through a complete client assessment with my client Leanna Rinaldi. In this assessment, I will explain possible compensations performed in each assessment, along with the areas they are found in. I will be identifying the compensations the client is performing, and I will list the muscles that are hyperactive or hypoactive for each compensation. First, we start with the static assessment. The static assessment is an observation of the client's posture using the kinetic chain checkpoints. The kinetic chain checkpoints are the head and cervical spine, the shoulders and the thoracic spine, the lumbopelvic hip complex, the knees, and the foot and ankle. This assessment is done in anterior, lateral, and posterior views. From the anterior view, the foot and ankle should be straight and parallel, not flattened or externally rotated. The knees should be in line with the toes and not valgus or varus. The lumbopelvic hip complex should have the pelvis level to the horizon. The shoulders should be level, not elevated or rounded, and the head should be in a neutral position, neither tilted or rotated. From the anterior view, you can see compensations like her elevated right shoulder. The muscles that would be underactive for the elevated right shoulder would be the deep neck flexors, rhomboids, middle and lower trapezius, and the serratus anterior. The overactive muscles would be the cervical extensors, pectorals, upper trapezius, and the levator scapulae. From the lateral view, the foot and ankle should be in neutral position with the leg vertical at a right angle to the sole of the foot. The knees should be in neutral position, not flexed or hyperextended. The lumbopelvic hip complex should have the pelvis in neutral position, not anteriorly or posteriorly rotated. The shoulders should be in line with the hips and ears, and the head should be in a neutral position, not in cervical extension. From the lateral view, you can see compensations at the knee. She has knee valgus and hyperextension. The muscles that would be underactive for these compensations are the abdominals, gluteus maximus and medius, and the hamstrings. The overactive muscles would be the hip flexors, lumbar extensors, and the gastrocnemius and soleus. From the posterior view, the foot and ankle should have heels straight and parallel, not overly pronated. The knees should be in a neutral position, neither valgus or varus. The lumbopelvic hip complex should have the pelvis level to the horizon. The shoulders should be level, not elevated nor rounded forward, and the head should be in a neutral position, neither tilted nor rotated. From the posterior view, you can see pes planus in her feet. The muscles that are underactive for pes planus would be the posterior tibialis, anterior tibialis, vastus medialis, gluteus maximus, gluteus medius, hip external rotators, hip flexors, and thoracolumbar paraspinals. The overactive muscles would be the gastrocnemius, soleus, peroneals, adductors, iliotibial band, iliopsoas, and hamstrings. The next assessment is a transitional assessment, the overhead squat. The overhead squat assessment is designed to assess dynamic posture, core stability, mobility, and neuromuscular control of the whole body during a squatting motion. From the anterior view, we are observing the feet, knees, and lumbopelvic hip complex. The feet and hips should remain in the sagittal plane with the knees tracking in line with the foot. The LPHC should not shift from side to side or rotate. We are looking for potential movement impairments such as feet turned out, valgus or varus knees, asymmetric weight shift, or scapular elevation. In my client's assessment, you can see her feet are turned out, she has valgus knees, and there is weight shift towards her left side. Her feet turn out because she has overactive biceps femoris, gastrocnemius, and soleus. She also has underactive anterior tibialis, gastrocnemius, gluteus maximus, gluteus medius, hamstrings complex, and posterior tibialis. Her valgus knees come from an overactive adductor complex, biceps femoris, gastrocnemius, soleus, tensor fascia lata, and vastus lateralis. The underactive muscles are the anterior tibialis, gluteus maximus, gluteus medius, hamstrings complex, posterior tibialis, and vastus medialis oblique. The weight shift to her left side comes from overactive left adductor complex and tensor fascia lata, as well as overactive right biceps femoris, gastrocnemius, soleus, and piriformis. The underactive muscles are her core stabilizers, left gluteus medius, and right adductor complex. From the lateral view of the overhead squat assessment, we are observing the feet ankles, knees, LPHC, shoulders, and head from the side. The heels should stay on the ground. The pelvis and spine should remain in a neutral posture. The torso should remain in parallel with the tibia while the arms stay in line with the torso. The head should remain neutral. We are looking at potential movement impairments such as heel rise, knee dominance, excessive anterior pelvic tilt, excessive posterior pelvic tilt, excessive forward trunk lean, arms falling forward, or a forward head. In my client's assessment, you can see heel rise and some excessive forward trunk lean. The heel rise comes from overactive quadriceps complex and soleus. The underactive muscles are the anterior tibialis and the gluteus maximus. The excessive forward trunk lean comes from overactive adductor complex, external obliques, gastrocnemius, psoas, rectus abdominis, rectus femoris, soleus, and tensor fascia lata. The underactive muscles are the anterior tibialis, gluteus maximus, hamstrings complex, local core stabilizers, and the spinal extensor complex. From the posterior view of the overhead squat assessment, we are observing the feet, ankles, and shoulders from the back. The arch of the foot and calcaneus should remain in neutral position. Shoulders and scapula should be neutral. We are looking at potential movement impairments such as excessive foot pronation, asymmetric weight shift, and scapular elevation. Okay. In my client's assessment, you can see her feet are turned out. There is excessive foot pronation and weight shift to the left side. The feet turned out are due to overactive biceps femoris, lateral gastrocnemius, and soleus. The underactive muscles are the anterior tibialis, medial gastrocnemius, gluteus maximus, gluteus medius, hamstrings complex, and posterior tibialis. The excessive foot pronation comes from an overactive fibularis complex, lateral gastrocnemius, and tensor fascia lata. The underactive muscles are the anterior tibialis, medial gastrocnemius, gluteus maximus, gluteus medius, intrinsic foot muscles, and posterior tibialis. The weight shift comes from overactive left adductor complex and tensor fascia lata and right biceps femoris, gastrocnemius, soleus, and piriformis. The underactive muscles are the core stabilizers, left gluteus medius, and right adductor complex. The next assessment is another transitional assessment, the single leg squat. The single leg squat assesses dynamic posture, strength, balance, and overall neuromuscular control, only in a more advanced single limb stance. From the anterior view, we are observing the feet, knees, and LPHC from the front. The feet and hips should remain in the sagittal plane with the knees tracking in line with the foot. The LPHC should remain level and not rotate or shift from side to side beyond what is needed to first obtain balance. We are looking at potential movement impairments such as valgus or varus knees, asymmetric weight shift, inward trunk rotation, and outward trunk rotation. From the lateral view, we are observing the feet, ankle, knees, and LPHC from the side. The heels should stay on the ground. The pelvis and spine should remain in a neutral posture. The torso should remain parallel with the tibia. The potential movement impairments are heel rise, knee dominance, excessive anterior pelvic tilt, excessive posterior pelvic tilt, and excessive forward trunk lean. From the posterior view, we are observing the feet and ankles from the back. The arch of the foot and calcaneus should remain in a neutral position. The potential movement impairments are excessive foot pronation. In my client's assessment, you can see inward trunk rotation and knee valgus. The inward trunk rotation comes from the overactive adductor complex and tensor fascia lata. The underactive muscles are the gluteus maximus, gluteus medius, and local core stabilizers. The knee valgus comes from an overactive adductor complex, biceps femoris, gastrocnemius, soleus, tensor fascia lata, and vastus lateralis. The underactive muscles are the anterior tibialis, gluteus maximus, gluteus medius, hamstrings complex, posterior tibialis, and vastus medialis oblique. The single leg squat on the right leg showed the same compensations of inward trunk rotation and knee valgus as on the left leg. It also showed excessive trunk movement and weight shift. The overactive muscles for excessive trunk movement and weight shift are the adductor complex, tensor fascia lata, biceps femoris, gastrocnemius, soleus, and piriformis. The underactive muscles are the core stabilizers, gluteus medius, and the adductor complex. The next assessment was the mobility assessment for dorsiflexion. The normal mobility for the dorsiflexion test is that the client is able to touch the wall with the forward bending knee without compensation. Compensation would be heel lift, foot external rotation, arch collapse, or knee valgus. When the test knee is the right knee, you can see the client's left foot demonstrates foot external rotation and heel lift. When the test knee is the left knee, you can see the client's right foot demonstrates external foot rotation, heel lift, and knee valgus. The overactive muscles are the gastrocnemius and soleus. The underactive muscle is the anterior tibialis. The next assessment was a mobility assessment called the modified Thomas test. This test assesses psoas length, tensor fascia lata length, and rectus femoris length. Normal mobility for the Thomas test consists of the test side, hip, and thigh laying flat on the table in line with the torso without compensation, the femur resting in a straight line with the torso without compensation, and the knee hanging naturally at 90 degrees off the table edge without compensation. In this assessment of her right leg, my client demonstrates restricted knee flexion and restricted hip adduction. The overactive muscles are the tensor fascia lata and the rectus femoris. The underactive muscles are the hip adductor complex and the hamstrings. In the assessment of her left leg, she shows restricted hip adduction and restricted knee flexion. The overactive muscles are the tensor fascia lata and the rectus femoris. The underactive muscles are the hip adductor complex and the hamstrings. Gait is a dynamic assessment and can be viewed from anterior, lateral, and posterior angles. In the anterior view, we are observing the feet, knees, and LPHC from the front. The feet should remain parallel and in the sagittal plane with the knees tracking in line with the foot. The LPHC should not be shifting from side to side or rotating. In the posterior view, we are observing the feet and ankles from the back. The arch of the foot and calcaneus should remain in a neutral position with each step. In the lateral view, we are observing the LPHC from the side. The pelvis and spine should remain in a neutral posture. We should be looking for potential movement impairments such as feet turning out, valgus or varus knees, asymmetric weight shift, excessive anterior pelvic tilt, excessive posterior pelvic tilt, and excessive foot pronation. In her assessment, the client demonstrates valgus knees and excessive foot pronation. Excessive foot pronation comes from an overactive fibularis complex, lateral gastrocnemius, and tensor fascia lata. The underactive muscles are the anterior tibialis, medial gastrocnemius, gluteus maximus, gluteus medius, intrinsic foot muscles, and posterior tibialis.
Okay, go ahead.
The knee valgus comes from an overactive adductor complex, biceps femoris, gastrocnemius, soleus, tensor fascia lata, and vastus lateralis. The underactive muscles are the anterior tibialis, gluteus maximus, gluteus medius, hamstrings complex, posterior tibialis, and vastus medialis oblique. The Davies test is a dynamic movement assessment for identifying movement impairments during a repetitive plyometric activity for the upper extremity. The Davies test requires upper extremity agility, strength, and stabilization, and stability of the trunk and LPHC. We are observing the potential movement impairments such as excessive anterior pelvic tilt, excessive posterior pelvic tilt, excessive trunk movement, scapular elevation, scapular winging, and excessive cervical extension and forward head. In this assessment, my client demonstrates excessive trunk movement, scapular winging, and excessive cervical extension. The excessive trunk movement comes from underactive local core stabilizers. The scapular winging comes from the overactive latissimus dorsi, pectoralis minor, and upper trapezius. The underactive muscles are the lower trapezius, middle trapezius, and serratus anterior. The excessive cervical extension comes from overactive cervical extensors, levator scapulae, sternocleidomastoid, and upper trapezius. The underactive muscles are the deep cervical flexors, lower trapezius, middle trapezius, and the rhomboids. That is my complete client assessment.